Hello everyone, welcome to today's live broadcast, Vitamin D, Health Disparities in Prostate Cancer and Alzheimer's. I'm Robert Castellanos of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon at the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the C button located in the bottom left-hand corner of your webpage and follow the process of attaining your credits. I would like to introduce today's speaker, Dr. Sebastiano Gattoni Celli. Dr. Gattoni Celli received his MD from the University of Naples Medical School before completing his residency in oncology at the Catholic University Medical School in Rome, and a fellowship of molecular biology at New York University Medical Center. He is currently a professor of radiation oncology at the Medical University of South Carolina and health research scientist at the Ralph H. Johnson VA Medical Center in Charleston, South Carolina. For the past decade, vitamin D3 supplementation studies have been an important aspect of his research efforts. Specifically, he has explored the impact the hypovitaminosis D can have on the health of very large segments of the population. He is currently examining the possibility that long-term vitamin D deficiency may contribute to the progression of subclinical prostate cancer to clinical disease, especially among African American men. He is actively conducting clinical trials to determine whether vitamin D3 supplementation in patients diagnosed with early-stage low-risk prostate cancer will yield improved therapeutic, clinical, and survival outcomes. I'll now turn it over to the doctor for his presentation.
Hello, everyone. My name is Sebastiano Gattoni Celli, and we'll discuss today some of my work, the results of my work on vitamin D, prostate cancer in African Americans, and towards the end of my presentation, some interesting observations which had to do with vitamin D as a possible preventive agent for Alzheimer's. Vitamin D is made by us, therefore it's not really a vitamin because we make it in our skin when we get exposed to the sun. This compound is called cholecalciferol, and once released in the blood, ends up in the liver where it's modified by hydroxylation in position 25. The ensuing compound is called 25-hydroxyvitamin D3, which has a half-life of about 2 weeks. And that's important because that is the compound we measure to find out whether we have sufficient circulating levels of vitamin D. Cholecalciferol instead has a half-life of only 24 hours. After the formation of 25-hydroxyvitamin D3 or 25-HT, this compound ends up in the kidney, but also in other organs. In the kidney, there is a second modification, hydroxylation position 1, which makes the mature hormone 125 dihydroxyvitamin D3. This is a powerful molecule, and this is the one that is responsible for bone mineralization, absorption of calcium through the intestine, reabsorption in the kidney. However, the topic of this talk will not be really much at all on bone mineralization, but on other topics which actually can be more important for justifying the relevance of vitamin D in our health. So we will be talking today about vitamin D3. That's the animal form of vitamin D. The plant form is called vitamin D2, but it's just for your information. In good conditions, in conditions in which we make plenty of cholecalciferol or vitamin D3, which is stuff that you essentially find at the drugstore or at Walmart, all the compartments which have to do with vitamin D metabolism are full and happy. What most people don't realize is that in real life, the only compartment which stays full is essentially one which has to do with the kidney, because plasma levels of 125-OH2D are crucial essentially for our survival and for maintaining the appropriate calcium levels in the serum. However, all the other compartments are really deficient. And this affects a lot of other functions which have nothing to do with bone, but which have a lot to do with our well-being in terms of diabetes, cancer, and Alzheimer's disease. So we really have to tackle the importance of vitamin D supplementation in order to prevent this dire situation, which is extremely common in African Americans. So when we go to the pool in our trunks and we spend some good time having a good time at the pool, we basically make about 20,000 international units of vitamin D. That's a lot of vitamin D, and which is why, you know, by the end of a pool day, we feel very good. I want to make the point that 20,000 units of vitamin D are non-toxic, because actually when you leave the pool you feel very well. So the problem is that in African Americans there is melanin. Melanin actually works as a shield, and so they need tenfold longer time exposure to be exposed to the sun in order to make a sufficient level, and at our latitudes that's really problematic. So in real life, people that live in sub-Saharan Africa do not have a problem as long as they are exposed to the sun rather than living inside or being heavily clothed. If you go up north or if you go down south, now vitamin D levels will be lower in the winter because of the angle of the sunlight. And of course, if you go further north, there is really a problem, because for more than 6 months, people cannot make their own vitamin D. So supplementation has become an important issue, also because if you spend too much time in the sun, your dermatologist will yell at you. So you really, supplementation is really a way to achieve the levels which are good for, appropriate for your well-being. And how do we know that melanin is a shield? Well, we know because it turns out that 97% of the people of European descent, 97% again, have a mutation in this gene. This gene is essentially one responsible for producing melanin in our skin. And this gene apparently got mutated 6,000 to 10,000 years ago, when essentially the agricultural societies were established. At that time, the diet changed dramatically, and rather than getting vitamin D through their food, mostly raw meat, people became suddenly deficient. And it is speculated that this created a collapse of the hip bones because of deficient calcification. And that created a problem for women delivering their children. So this mutation allowed that to be overcome, and it's amazing the fact that a mutation had to occur to allow for vitamin D to be processed it tells you how important that has been in evolution and for Darwinian selection. So if we look at the evolution of the human species, we know that people, Africans living in sub-Saharan Africa have generally appropriate levels. And things change when we go to higher latitudes, and especially in the winter. So supplementation can compensate for that. But as you can see, 1,000 units per day, which is what most physicians counsel the patients to take, is really not sufficient to reach blood levels which are comparable to the ones that we should have, about 120 nanomoles, which is essentially 40 to 50 nanograms per ml of serum. So we really need to take 4,000 units per day at least. And why 4,000 units per day? Because 4,000 units per day is what is called a tolerable upper level intake for vitamin D3. And this level has been established by the Food and Nutrition Board of the Institute of Medicine. This is an important recommendation, and this is the dose that we have been using for our clinical trials, because these clinical trials have to go through the scrutiny of the FDA. And the FDA will listen to the IOM recommendations. It's important that, however, the general recommendation is for 600 units of vitamin D per day in everyone from a 200-pound adult to an 8-pound baby. And, so it tells you that these recommendations may not be adequate, and certainly it's good that we have some upper level intake, tolerable upper level intake, at least to pursue our studies. So the bottom line is that minimal levels of vitamin D are sufficient to prevent rickets, but we need much more than that for other functions that we will be discussing very shortly. And certainly for what we call normal functions. Normal functions affect all those organs which make their own vitamin D hormone, but rather than releasing it like the kidney does, which is the only endocrine organ in terms of vitamin D production. All the other organs, the prostate, the breast, the skin, the brain, they sequester it, and in those tissues, vitamin D works autochronally. Of course, if they don't have sufficient amounts of cholecalciferol, again, vitamin D3, if the individuals do not assume sufficient amounts of vitamin D3, they simply will not have enough substrate to make their own hormone for their use in each organ. So how do we know that vitamin D is important for cancer? Well, that was really the result, the serendipitous result of a study that actually was looking at spontaneous fractures and bone mineralization. And the study involved about 1,200 women, and they were randomized to a number of different conditions, one of which was vitamin D plus 1,100 units of D3 per day. And they were followed for, this was a 4-year trial, so it was a long trial, and interestingly, the follow-up revealed something which was totally surprising. So it turns out that the most important outcome of this study was the number of events, cancer events, experienced by each arm. And you can see that the arm that had both calcium and vitamin D had half of the cancer events experienced by the placebo arm. So all of a sudden, we paid attention to the result of this very well run clinical study, which was longitudinal and carefully monitored. So let's go back to the main topic of this talk, which is that our organs other than the kidney make their own vitamin D, and as I told you, they sequester it and works locally. The macrophages, which has to do a lot, is one of the most important cells which are part of our immune response. The skin, of course, colon, prostate, breast, and brain. And so the in these organs, the hormone is the 125 is being produced, synthesized, and works on a works on a nuclear receptor, which is the vitamin D receptor, and then there is association with a co-receptor, and this complex binds to to vitamin D response elements. Vitamin D response elements, or VDRE, are extremely interesting sequences which are in the promoter part of a gene, and therefore regulate the transcription, meaning the expression of that particular gene. And to a fairly recent count, there are about 1,000 vitamin D response elements in the genome, which suggests that about 1,000 genes in the genome are responsive to vitamin D action. And so if you are not, if you are deficient, that basically does not happen. And that is a problem, because these genes have to do with anti-proliferation and immunomodulation activity. So this means that these genes control the rate at which cells multiply and our immune response, which is fundamental to keep us healthy from cancer. So vitamin D and prostate is a topic that has been interesting to me for many years. The main reason is that prostate cancer is oftentimes an indolent disease, and so basically it would be an ideal cancer on which to test a really non-toxic intervention, which is patient-friendly, and essentially the subject can self-medicate, doesn't have to come to the clinic, and we can monitor the compliance of subjects enrolled in a study by virtue of the fact that their vitamin D levels have to go up if they are compliant. So prostate cells have the vitamin D receptor. They make their own calcitriol, which is the hormonal form of vitamin D, the 125 or H2D3, and it's well established that this hormone can inhibit both in vivo and in vitro cell proliferation of prostate cells. So that was certainly a valid rationale for treating people with supplementation and see whether their cancers were affected. This is a crowded slide, but I want to point out to your attention essentially two things. One of the actions of vitamin D is on cell cycle arrest, meaning vitamin D allows the cells to slow down in terms of proliferation. The other thing I want to point out to your attention is the action that vitamin D is in mitigating the activation of NF-kappa B. What is NF-kappa B? NF-kappa B is a transcription factor, which is essentially the general that determines the triggering of inflammation in our body. And so NF-kappa B is a transcription factor which binds to the promoter of a lot of cytokines which are released when the body experiences phenomena of inflammation, like having the flu or things of that sort. Why is that important? Because inflammation really has been clearly demonstrated as a cofactor in the progression of cancer. And in case of prostate cancer, you can go from non-clinically relevant prostate cancer to clinically relevant prostate cancer. But anyway, all of these actions are promoted by vitamin D, and they essentially are all inhibitors, not only of cancer progression, but also of fatal cancer, like inhibition of invasion and metastasis. So we designed a first prospective study to find out whether there was any effect of vitamin D, and our first objective was to see whether there were effects on PSA. So we enrolled subjects that had diagnosed prostate cancer because of biopsy, but we looked for subjects with Gleason score of 6 or less. We got an IND, we obtained an IND to perform this study from the FDA to make sure that we were monitored for any toxicity, and I can tell you there was none. The subjects diagnosed with low-risk prostate cancer were decided to be monitored by something called active surveillance. In other words, they defer definitive treatment because the cancer actually may never progress. It's well established that most men die with prostate cancer, but not of prostate cancer. So, frankly, treatments like surgery especially, but also radiation therapy have side effects significant like impotence and incontinence. And so active surveillance is entirely adequate for low-risk prostate cancer for cases in which there is no impending progression of the cancer. The primary objective was really to look at whether vitamin D given for 1 year at 4,000 international units per day had an impact on the PSA levels. And as a secondary objective, we wanted to compare the outcome of prostate biopsy, which is performed periodically to find out whether the cancer progresses. In other words, if there are positive cores which are increasing in number or increasing in severity. So, with this in mind, let me tell you about the diagnostic workup for prostate cancer. Probably most of you are aware, but currently 12 cores of tissue from the prostate are acquired by the urologist and essentially fixed and stained and examined by the pathologist. The cores which are the most important are the ones on the outside of outside part of the gland, which is the peripheral zone, because that is the part of the gland in which new cancers tend to emerge. So once you add this kind of test, first of all, the pathologist will tell you whether or not any cancer is detected. And if cancer is detected, we'll give an estimation of the severity by using the Gleason score. If the Gleason score is up to 6, it's most likely that the cancer is low risk. If the Gleason score is more than 6, then an extended discussion has to occur between the patient and urologist to decide on possible interventions. Anyway, we only enroll subjects that had Gleason score of 6 or less, and subjects, therefore, who decided to selected not watchful waiting, but monitoring of their cancer. So, active surveillance. So, at the end of this study, we noticed that actually there was a drop in the subjects we enrolled and which were supplemented, and we knew that they were supplemented because the vitamin D levels went up to about 60 nanograms per ml of serum, so obviously they were replete. And we compared these with historical controls, in which case, naturally, the number of positive cores go up over time. So that was comforting. But even so, we really needed to run a randomized study, which is what we are running now. And I'll let you know shortly about an interim analysis we have done of that study, which is still continuing accrual. So as part of this study, we learned something that was quite interesting. So this graph shows you what at baseline, what are the levels of vitamin D between African American subjects and white subjects. And the difference is really significant. In other words, African American subjects tend to be much more prone to being vitamin D deficient, not so the white subjects. However, after only 2 months of supplementation, there was really no significant difference between the two groups. And actually, at 1 year of supplementation, the two groups were indistinguishable. However, we paid attention to the fact that 2 months was sufficient to eliminate differences across race. And so, and this was important to design an additional study after the randomized study that we are still running, to look at what happens in the prostate, in the tissue, using some fairly advanced techniques, one of which is called RNA sequencing. So I'll skip this slide because I may not be as informative for you. So the difference in vitamin D levels between the two groups, which was very clear and has been documented by a lot of investigators, is important because it turns out that racial disparities in prostate cancer outcomes mirror racial difference in circulating levels of vitamin D. So, and this is important because the mortality of by prostate cancer of African Americans is way, way up and much higher than white subjects. So we asked the question, what happens if we supplement subjects that have undergone biopsy, have decided to undergo prostatectomy, and are supplemented in the meantime, and what happens to their tissues? Why is that? Okay, so 2 months, it seems to be a sufficient interval of time to eliminate differences across race. The other thing is, the other point is that as for standard of care, 2 months are an interval required between the biopsy and the prostatectomy because the inflammation of the gland has to be has to abate before surgery is performed. So at time of surgery, we had the opportunity to obtain non-neoplastic tissue from these subjects and essentially extract, purify the RNA, and perform what is called RNA sequencing. RNA sequencing is a very new approach. It's a fairly new approach to essentially get the sequence of all the possible transcripts from a piece of tissue from a particular study subject. In practical terms, this means that each subject will be identified by 20,000 data points, because that's very close to the number of genes that each subject has. And so we have a very large number of set of data to look at what is the expression within the prostate with and without supplementation and across races. So this is a fancy slide which tells you that we use messenger RNA extraction and we perform RNA sequencing. And for doing these things, you need complex machines, you need, and for the analysis of the data, you need supercomputers. No big deal. These things are now available in most academic medical centers. And this is another fancy slide that tells you that you need a lot of computing power in order to analyze this data. But this is the table of subjects we enrolled. We enrolled a total of 27 subjects, 17 Caucasians and 10 African Americans. The 17 Caucasians were used as a control, and the African American patients were the experimental. However, each group was randomized to other vitamin D supplementation or not. So the one indicates the subject that were supplemented, and you can see, for instance, that in this particular subject, the levels at baseline increased rapidly after 2 months to considerable levels. So this was a prospective interventional study with the purpose of analyzing the expression of the RNA in within the prostate tissue across race and depending on supplementation. So this is a summary slide which tells you that RNA-seq was performed on the RNA of 27 patients using 2 distinct instruments to validate the data. And then the data underwent what is called integrative analysis. What is the purpose of that? The purpose is to see how significant are any differences if there are. And the differences were incredibly significant, and they really surprised us. The first thing we found was that more than 3,000 genes were expressed differently between African American and whites at a false discovery rate of 0.1, which is extremely, extremely significant. This was really not a fluke, and we know that it was not from other data I'll present. The other thing is that at a full discovery rate of 0.4, which is less stringent but still significant, the number of genes which were differentially expressed were more than 8,000. That's about 1/3 of the genome. That is, again, we were very surprised, and so we dug into the data to understand a little bit more about that. So, and the kind of analysis you can perform when you have so many data, in order to understand what they mean, is you start looking for pathways, the impact on cellular components, the impact on biological processes, and there are highly sophisticated programs that allow you to look at pathway analysis. In other words, the question was, do these differentially expressed genes cluster according to certain pathways and certain cellular functions? And the answer actually was yes. The conclusion, and our paper had like 16 figures. The conclusion is that African American subjects showed a higher expression of genes associated with immune response and inflammation, which are the characteristic targets, essentially, of vitamin D supplementation. And considering that African Americans tend to be vitamin D deficient, that was not surprising. What surprised us was the extent of differential expression. And so, essentially, that was an indicator of the severity of the problem. The other thing was that when we analyzed the data a little bit more in detail according to these various pathways, the results were very clear. So on the right, you have the 10 columns representing each African American subject. On the left, the 17 columns representing each European subject. And red indicates overexpression, blue indicates underexpression. And it's very clear that for a lot of pathways that are intimately that are involved with essentially the immune response in general, the difference was very clear and very striking. I also want to point your attention to the differences found in NF-kappa B signaling, which specifically is affected by vitamin D. And again, once again, there were clear differences between the two racial groups. So, does this mean anything? Well, there was a paper published in 2008 by Wallace and co-workers. They used a different technology, which was not as advanced because that was 2008, and they used something called Affymetrix. By using that, and that was actually a retrospective study, but by using this technique, they identified almost 500 genes which were differentially expressed between blacks and whites. So what we did, we looked at those genes, and essentially we captured all of them. So basically, our results confirm that kind of analysis, and also confirm the results. You see, the African Americans are all in red, the Europeans are all in blue. So this is tremendous racial difference, which go to the biological level. And so not only we captured that, but we also demonstrated that these differences are much more extensive just by virtue of the fact that what we used was a more advanced technology. And this is just a chart to show you that there were differences at the beginning in terms of vitamin D levels, and that these differences were compensated in African Americans using only 2,000 in only 2 months using 4,000 units per day, and that basically at the end of the treatment there were no differences between African Americans and whites who had been supplemented with vitamin D. So what happens to the gene expression after vitamin D selection? Well, we basically found that about 350 genes were modulated. Bear in mind, this was an intervention that lasted only 2 months and affected, and we analyzed the effects of these supplementation only at a prostate level. However, keep in mind that if you had this supplementation for 1 year or longer, this overlap would be much, much larger. And so when we looked at the type of genes that were altered in expression by the vitamin D treatment, essentially we got the same response that we got previously, meaning chemokine receptors and G protein coupled receptors, which essentially are controllers of cell proliferation. So again, these results are really consistent with the fact that vitamin D does affect those pathways which may be relevant in the progression from low-risk cancer to high-risk cancer, and that is particularly serious among African Americans. So the last thing we did was to look at possible differences between within the African American cohort between the ones that were supplemented with vitamin D and the ones who received placebo. And once again, we found significant differences. 124 genes were differentially regulated at a false discovery rate of 0.1, which is again extremely stringent. And one of the surprises was that one of the genes affected is the GDF15, which is a gene which is important for prostate cancer progression, which was actually activated by the it's activated by vitamin D, and actually in the cohort that received the treatment basically was upregulated. So let me tell you a little bit about now the ongoing randomized study, the supplementation, which occurs for 1 year in subjects that are enrolled that go for who have low-risk prostate cancer, who undergo who are monitored by active surveillance and basically are randomized to other placebo. Here you have the preliminary is 82 subjects, and vitamin D, by now we should be about 100 subjects and counting. And the first thing is that vitamin D supplementation works. So in the placebo arm, there is no difference between, there is some difference in what's in plaques, but essentially the baseline values are not terribly changed. But with vitamin D supplementation, the exit values are way different, much higher, and this means that these people are compliant. We really had no problems with compliance. We really cannot think of any subjects that did not take their vitamin D, which again is non-toxic and easy to assume because they do it on their own good time. So first thing we looked at is PSA, and again, PSA really did not budge between the two groups. These are the collected data for both groups, and again, this confirms what we saw in the if you look at the p-values, there is really no difference. Okay, so the PSA doesn't change. Again, this is confirmatory of the open label study. What changes is at the moment there is a trend toward a decrease of positive course at repeat biopsy in subjects who receive vitamin D. And what's interesting is that this trend is particularly clear in the African American part of the study, in the subjects, in the African American subjects, which to us makes sense because these are the subjects who tend to be vitamin D deficient to begin with. There is really not much of a difference in white subjects. Again, they tend to start with decent levels of vitamin D at baseline. So the study is still accruing, and we hope to find out that by the end of accrual and the end of analysis, these differences may be significant. So this is where most African Americans are in terms of vitamin D levels. They are really either deficient or insufficient, and they should be here. This is where they should be. They should be replete, and that would allow for, I think, a mitigation of the health disparities, not only in terms of prostate cancer, but also diabetes and hypertension. So that's really the objective, to encourage these people to get supplementation on their own. This is a cartoon that was lent to me by Dr. Bruce Hollis, who's really a world expert in vitamin D. I want to make 2 points: that there are certain actions of vitamin D which are not mediated by gene expression. In other words, they are immediate, they are direct, and they are due to the cholecalciferol. It has to do with endothelium stabilization, and it's something that actually has been used to justify massive doses of vitamin D3 at admission into the ICU to prevent septic shock. The other thing I want to point to your attention is that vitamin D goes to the brain, and again, the brain has all the enzymes to make its own hormones. So cholecalciferol goes to the brain through a megalin-mediated mechanism, just like in the placenta, and in the brain, the vitamin D becomes the vitamin D hormone, because the brain has the vitamin D receptor and all the enzymes to make its own vitamin D hormone. Why is this relevant? Because in the central nervous system, vitamin D controls the production of 2 important hormones, nerve growth factor, NGF, and glial-derived neurotrophic factor, or GDNF. And these are important molecules that essentially protect the integrity of our neurons. Not only, but vitamin D, because of its anti-inflammatory action, is essentially a protector against something called neurodegenerative diseases, and the worst one of which is Alzheimer's disease. So what we did was to test in an animal model of Alzheimer's disease whether a diet rich in vitamin D might have been helpful, or could give us some indication of whether might have been effective at slowing down or correcting the problems associated with Alzheimer's disease. Now, Alzheimer's disease is in the animal model in question, which is called the APP mouse, amyloid precursor protein. In this animal model, the transgene is a Swedish equivalent of an altered amyloid precursor proteins, which produce large amounts of the A-beta peptide. And the A-beta peptide is essentially a seed for what we call amyloid plaques, which are visible in the brain of people who are affected by Alzheimer's, not only the mice, but also human beings. So this is a convenient model to study corrective actions or intervention, which may slow down or prevent Alzheimer's disease. And so what we did was to randomize mice to either regular diet or a vitamin D rich diet, or a diet without vitamin D. And the mice were randomized immediately after weaning, and they were kept on these particular diets for 5 months. At 5 months, the mice were euthanized. But before doing that, the mice were tested for memory retention, and which, by the way, showed a difference. But what's important is that the brains, bones, and blood of the mice were collected and analyzed, and this is what we found. Well, we found that, first of all, a vitamin D-rich diet brought a higher level of circulating vitamin D in these mice compared to vitamin D-deficient diet, in which really the vitamin D levels were close to 0 and certainly did not budge. The second thing we found was that indeed vitamin D is needed for bone mineralization, because on the left you have the bone of a mouse that had a vitamin D rich diet. On the right, the bone of a mouse that had a vitamin D deficient diet, And there is this matrix, osteogenic matrix, which looks pinkish here, which is in great amounts in the mice with vitamin D, because of course they are hungry for calcium, and there is no calcium to be found because the calcium is not absorbed because vitamin D is not present. While in contrast, in the mouse receiving vitamin D rich diet, basically you could not find under the microscope not one shred of osteogenic matrix because there was plentiful of calcium and everything, and the bone was totally ossified, or totally calcified. So these we did just to make sure that the diets were doing their job. So then we went to the brain, and the brain on the left panels you see the brains of mice that received a vitamin D deficient diet. On the right you see the panels B, D, F, and H, referring to the brains analyzed by two different imaging techniques of the mice that received a vitamin D rich diet. And what you can see, not only that the number of plaques is very different, and there was significant difference, but what's more important is that the size of the plaques was very different. You see, the plaques in non-supplemented mice were much larger compared to the plaques that we observed in supplemented mice. And actually, these kind of stuff could be, these kind of parameters could be analyzed and quantified. And so here is the result. So we have two parameters, amyloid load, which is the total amount of amyloid, and amyloid plaques. Even though the amyloid plaques in mice which had a vitamin D deficient diet were more than the mice with vitamin D enriched diet, the difference didn't seem to be so, shall we say, was significant but not spectacular. But the amyloid load differences were spectacular because that takes into account the amount of amyloid, which is much larger. In other words, the number of plaques does not reflect the difference in amyloid load that you can measure in the brain. The other thing we did was to look at mediators of inflammation. And one of the most important mediators of neuroinflammation is tumor necrosis factor alpha. So basically, tissue extracts were prepared from the brain of the mice receiving a vitamin D deficient compared to the mice receiving a vitamin D enriched diet. And the difference was striking. So one can object and say, well, you know, maybe vitamin D brings down just about everything in the brain. And to clear you of that misconception, let's see what happens with the NGF, or the nerve growth factor. Well, the nerve growth factor essentially increases by at least threefold in the mice receiving a vitamin D enriched diet, and is very low in mice receiving a vitamin D deficient diet. So the point I'm trying to make is that, so, you know, for whoever in the audience is interested in neurodegenerative diseases, please take your vitamin D, go to Walmart, the drugstore, get your 5,000 units per day. And actually, this can be really a protector because what we see with the elder generation now, the generation of older people, who, by the way, are very often vitamin D deficient, is these epidemics of Alzheimer. So since we know it, let's use supplementation to possibly prevent this scourge. And of course, I could not have done all these by myself, and these are my collaborators, and thanks to them, we could bring to fruition a lot of work. And now I will leave the, so I'm done with my presentation, and I'll leave the word to the moderator, Mr. Castellanos.
Hey, thank you so very much for your informative presentation. Before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can for this event. Doctor, our first question is, As men over 50 are in risk of prostate cancer, will you recommend that men have daily over-the-counter vitamin D3 supplement?
Yes, absolutely, yes. I basically, all my friends know that I tell them, sometimes I bring them bottles of vitamin D and I tell them to take it, as many beneficial effects, but absolutely, anyone over 50, just pop your pill every day with your coffee, and I think that that's going to be very helpful. And you know, sometimes this can be coupled with selenium yeast, which is another, which actually we have some old evidence to suggest that actually the two, vitamin D and selenium, actually may work together against possible progression of prostate cancer. Anyway, my answer is absolutely yes. Do not hesitate, and it's not toxic.
Our next question. Can taking vitamin D supplements or spending more time in the sun help prevent Alzheimer's and other forms of dementia?
Well, the results of our animal studies indicate that. Because essentially by decreasing neuroinflammation and increasing the production of NGF and GDNF, I think that that is certainly as good a measure. And again, this is non-toxic. And you know, if you really want to crank up the supplementation, you can go to 10,000 units. The only recommendation I make is that if individuals come from families with a predisposition to kidney stones, they probably should drink quite a bit of water just to prevent the possibility that stones may form in the kidney. But otherwise, I can tell you through the hundreds of patients we've gone through, we have not seen any smidgen of evidence that vitamin D is toxic at all, even at high doses.
And can vitamin D supplementation treat depression or improve mood?
Well, that's an interesting question, because actually at our medical center, I know of some psychiatrists that suggest to their patients who experience depression to take healthy levels of vitamin D supplementation. So again, it's a neurotrophic factor. In other words, it stimulates. Look, when you go to the pool and you stay, you know, a couple of hours to the pool, generally speaking, you know, your appetite is up and you feel good. Okay, so I think that to have good levels of vitamin D probably really would improve your mood. And certainly, again, it has been indicated, not so much indicated, but certainly suggested to people who have depressive symptoms. By the way, does not interfere with anything that they may have to take for that condition.
All right, thank you, doctor. And it looks like we have time for one last question today. Are you aware of any studies with vitamin D and treating fibromyalgia?
I'm not aware of any studies, but I would guess, my educated guess is that if there are inflammatory components to fibromyalgia, which there are, healthy supplementation of vitamin D may only help.
And thank you, Doctor. And before we let you go today, do you have any final comments for your presentation?
Make sure you take your vitamin D. You will not be yelled at by the dermatologist, and your sense of well-being will increase. It takes about 2 months to be replete, but after that, you will experience that you are in better shape. You will not be prone to colds, and if you get a cold or even a mild flu, it's going to be mild indeed in terms of duration and severity.
I'd like to once again thank the doctor for his time and presentation. I'd also like to thank Labroots for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through February of 2017. You'll receive an email from Labroots alerting you when this webcast will be available for replay. We'd like to invite you to forward that announcement to your colleagues who may have missed today's live presentation. Until next time, goodbye.